Hello everybody and welcome to our module on the salivary glands. There are three major salivary glands found in the human body. You should know that there are also many tiny glands that are found throughout the mouth, and all of these glands work to produce saliva, which helps in digestion, as we'll discuss in this module. There are two salivary glands found below the mouth. The first one is called the submandibular gland. This is a picture of where the submandibular gland here is on this slide. You can see that it's just below the mandible, hence the name submandibular gland. And it secretes saliva into Wharton's duct from which it reaches the mouth. The second salivary gland found below the mouth is called the sublingual gland. This is found on the floor of the mouth below the tongue, hence the name sublingual. This is a picture of where it's located here on the screen. And then the largest of the salivary glands is the parotid gland. It's found behind the angle of the jaw as shown in the picture here. It's below and in front of the ears, and it's the biggest of the three salivary glands. Saliva is mostly made up of water. More than 90% of saliva is water, but it also contains other substances including mucin and glycoproteins. These help to lubricate your food so that it can pass into the stomach. They also bind bacteria to prevent infections. From an immunology point of view, you should know that saliva contains a significant amount of IgA antibodies. This is a picture of the structure of IgA antibodies on the screen here. I talk about these antibodies in more detail in the immunology modules, but they bind to bacteria and prevent them from entering the mucosa. Also found in saliva are proteins called lysozymes, which disrupt bacterial cell walls. You can also find a substance called lactoferrin. The word lacto is in the name because it's also found in breast milk, and the word ferrin is in the name because one of the things lactoferrin can do is bind to iron, and it prevents bacterial growth. And then finally, you can find many proteins that help to protect your teeth from decay. Saliva is an important component of innate immunity. The innate immune system is our immune system that can react sort of at a moment's notice, in contrast to the adaptive immune system of B and T cells, which takes several days to get going. And saliva is part of the innate immune system and therefore protects us against infectious agents. And one clinical tie-in of this has to do with Sjogren's disease. Patients who have Sjogren's disease have an autoimmune condition that results in the loss of tears in the eyes and saliva in the mouth. And when they lose saliva in the mouth, they get recurrent infections, and dental caries or cavities are a major problem for patients with Sjogren's disease. There are two important enzymes for digestion that are found in saliva. The first one is alpha amylase, which helps to digest carbohydrates. Amylose is a starch and is a carbohydrate, so amylase digests starch or carbohydrates. And then also found in saliva is lingual lipase, which helps to digest lipids. You may know that there is also an alpha amylase secreted by the pancreas. Salivary amylase has an optimal pH of greater than 6, so when it reaches the stomach it becomes inactive. Pancreatic amylase is secreted then in the duodenum and functions in the small intestine. There is also a pancreatic lipase, just like there is a salivary or lingual lipase. Salivary lipase is a minor contributor to lipid metabolism in adults. It's probably most important in newborn babies because they have lower pancreatic enzyme levels. In the adult, however, pancreatic lipase is the major player in digestion of fats and lipids. Let's talk about the electrolytes that are found in saliva. There are two important cell types responsible for production of electrolytes in saliva. The first cell type are the acinar cells, the second are the ductal cells. The word acinar means berry, so the acinar cells are the cells found in this berry portion of a salivary gland, and then the ductal cells line the duct going out to the mouth. And salivary fluid is produced by the acinar cells and then modified by the ductal cells. The initial fluid produced by the acinar cells is similar to plasma. It's isotonic to plasma, and it has the same sodium chloride, potassium, and bicarb concentration as plasma. If you look at this drawing I've made on the screen here, this is the acinous portion right here, and sodium chloride, potassium, and bicarb are all being secreted into the acinus, and they are at the same concentration as plasma. As the fluid moves through the duct, however, sodium and chloride are removed, and potassium and bicarb are secreted. The secretion of bicarb helps to raise the pH, and this protects against acid in the mouth when you eat food that can be damaging. The net result is that the fluid that reaches the mouth is going to have a lower sodium and chloride concentration than plasma and a higher potassium and bicarb concentration than plasma. So I've summarized these points on this slide here. Saliva becomes hypotonic relative to plasma because of the removal of sodium and chloride by ductal cells. There is a lower concentration of sodium and chloride in saliva than in plasma. Saliva also has a higher concentration of potassium and bicarb than plasma, and that's because of secretion of potassium and bicarb by the ductal cells. The electrolyte composition of saliva varies with flow rate. This is similar to what happens in the pancreas. When there's higher flow, there's less time for the ductal cells to modify the fluid, so the fluid becomes more like plasma more like the fluid that was secreted initially in the acinus. It becomes closer to isotonic with plasma. If we go back to this slide here, when the fluid is secreted by the acinus, it is initially isotonic with plasma. It becomes modified as it moves through the duct, but at higher flow rates it moves through the duct so quickly that there's less modification and the fluid becomes closer to that of plasma, closer to what it was initially when it was secreted into the acinus. The concentration of bicarb in saliva also goes up at high flow rates. The reason for this has less to do with the flow rate of saliva. It has more to do with metabolism. When there is a higher flow of saliva, there's more metabolism in the glandular cells, therefore they generate more carbon dioxide. This leads to more bicarbonate going out in the saliva. Aldosterone is a hormone that you probably think of as affecting the kidneys, and that's true, but you should know it also affects many other tissues, including the salivary glands. It can also affect the sweat glands and the colon, and it does the same thing in the salivary glands that it does in the kidneys. It promotes sodium absorption and potassium secretion. This is probably a minor contributor to the effects of aldosterone on electrolytes. The major contributor is the kidneys, but I just want to point out to you that the same type of effects are seen and have been described in the salivary glands. The regulation of salivary flow is interesting. It is regulated by both the sympathetic and parasympathetic systems. Importantly, it's not regulated by any gastrointestinal hormones, so the GI hormones like gastrin and secretin and cholecystokinin, they have no effect on salivary flow. The sympathetic effect on salivary flow is relatively small. The much greater effect is from the parasympathetic nervous system. This is the major system that stimulates salivary flow, just like it's the major system that can activate other digestive features of the GI tract, like acid secretion and hormone secretion. When you smell food or you look at food, you will activate your parasympathetic nervous system, and that will get saliva flowing. And the most important receptors are the muscarinic receptors M1 and M3. There's a tie-in with pharmacology here that has to do with the regulation of saliva. Drugs that work as muscarinic antagonists are going to cause dry mouth because they block the production of saliva. So when drugs are administered like atropine or scopolamine, they're going to have side effects of causing dry mouth. Conversely, when you give drugs that are muscarinic agonists, these will increase saliva production. So for example, pilocarpine is a muscarinic agonist. It's used in Sjogren's syndrome in order to stimulate saliva production. Organophosphate poisoning is something that can happen to farmers exposed to certain pesticides. Organophosphates inhibit the breakdown of acetylcholine, so they boost the levels of acetylcholine generally throughout the body, and one of the effects this has is to cause salivation. Drooling and salivation is a classic finding in patients with organophosphate poisoning. Now that we've talked about how the salivary glands work, let's talk about some pathology. And the first thing we'll discuss is sialolithiasis, which means a stone in the salivary duct. This is a picture of some stones removed from salivary ducts. They're usually made up of calcium, and you can think of them as similar to kidney stones. They precipitate out of the fluid and they obstruct the flow of saliva. The result is pain and swelling in one of the salivary glands. It's usually aggravated by eating. When you eat, you try to increase the flow through the salivary gland, and that can't occur because it's blocked by a stone, so the patient develops pain. It's most common in the submandibular glands, and risk factors are basically anything that decreases the amount of flow through the salivary gland. So if you are dehydrated or on diuretics, these people are more prone to develop salivary duct stones. If you are taking anticholinergic medications, which blunt the flow of saliva, that can also increase your risk. Usually they're treated with NSAIDs and hydration. Rarely they require surgery to remove a large stone. Sialidinitis is inflammation of a salivary gland, and this is usually due to bacterial infection on top of an obstructing stone. Most commonly this is secondary to Staph aureus, although these types of infections often also contain anaerobes. Usually they're treated with double coverage, something like nafacillin to cover the staph, and something like metronidazole or clindamycin to cover the anaerobes. Mumps is a clinical syndrome caused by the RNA mumps virus, and you almost never see this in the modern era because of vaccination. The MMR vaccine, which is a vaccine against measles, mumps, and rubella, is administered to all children in the United States, and as a result you rarely see cases of mumps. But you should know that a key feature of mumps is parotitis. This is often bilateral, and it's inflammation of the parotid glands, which presents as facial swelling. This is a picture of a child with mumps on the screen here. Our last topic for this module are the salivary tumors. These are rare tumors that usually present in the parotid gland, and for that reason they often present as facial swelling, just like that child with mumps we saw in the last slide. Most salivary tumors are benign, and this means that they are often mobile. They are benign, and therefore they don't grow into other tissues, and that creates a mobile mass in the face. In addition, they are usually painless, and that's because they are not invading the nerves surrounding the face, and therefore they're not causing any pain. When pain is present in a patient who has a salivary tumor, that usually indicates an invasive lesion. And in addition, some of the invasive types of salivary tumors can involve the facial nerve, which by way of review is the motor innervation to the face, and this can result in paralysis of part of the face. The most common type of salivary gland tumor is called a pleomorphic adenoma. It's also sometimes referred to as a benign mixed tumor, and as the name implies, it is usually benign. Rarely it can undergo malignant transformation, and when this occurs, it often causes pain and facial nerve dysfunction, as I talked about on the last slide. The most common location is in the parotid gland in the superficial lobe, which will present as a painless mobile mass at the angle of the jaw. The buzzwords you want to know for step 1 regarding this tumor are epithelial and stromal tissue cells. The reason it is called a mixed tumor or a pleomorphic tumor is because it contains a mixture of different cell types. One cell type is an epithelial cell type. These are glandular cells. If you look at this slide on the screen, on the left side of the screen you can see nuclei tightly packed together. Those are the glandular cells. On the right side of this picture there are nuclei that are further apart with lots of tissue between them. Those are stromal cells. They can produce cartilage and sometimes even bone. And characteristically in these tumors you see a mixture of both epithelial cells and also stromal cells. A major risk factor for these tumors is prior radiation to the head and neck. The treatment usually involves surgery plus or minus radiation therapy, and these can have a local recurrence, and the reason is because they often have irregular margins, so the surgeon may leave behind a small bit of the tumor and then that will begin to grow and you will get a recurrence later on. The second most common type of salivary tumor is called a Warthin's tumor. It's also sometimes called a papillary cystadenoma lymphomatosis. This usually occurs in the parotid gland, just like most of these salivary tumors. And a major risk factor here is smoking. This tumor is 8 times more common among smokers than non-smokers. There are 2 key histology findings you need to know about this tumor for step 1. The first is the presence of cysts filled with fluid. That's why it's called a cyst adenoma. If you look on the screen here, you can see large fluid-filled cysts in this biopsy specimen. Now the cysts are surrounded by dense lymphoid tissue. You can see lymph tissue surrounding these cysts on the screen here. And this lymph tissue sometimes aggregates into germinal centers. And that's another key feature to know about these tumors, lymph tissue that may aggregate into germinal centers. The last salivary tumor that we'll discuss is called a mucoepidermoid carcinoma. This is the most common malignant salivary tumor. Remember what I told you before, most salivary tumors are benign. And an important risk factor for this salivary tumor is prior radiation. So for example, a child who has lymphoma and receives radiation to the head and neck is at risk for developing this cancer later in life. It occurs in the parotids, although it's also commonly found in some of the minor salivary glands. And when it occurs in the parotids, because it's invasive, it sometimes invades the facial nerve, and that can lead to weakness or paralysis on one side of the face. In addition, because it's invasive, it can also cause pain. The reason it's called a mucoepidermoid carcinoma is because it contains a mixture of mucus-secreting cells and epidermoid or squamous cells. And this is what you want to know for step 1, that squamous and mucus-secreting cells are found inside of these carcinomas. This is a biopsy specimen of a patient with mucoepidermoid carcinoma. These tumors can have a very wide range of appearance under the microscope. There really isn't a classic histological appearance that you need to recognize. The most important thing to know is that there will be a presence of both squamous and mucus-secreting cells. And that concludes our module on the salivary glands.